Good morning, good afternoon, and good evening, depending on wherever in the world you are signing in from. I'm Kavita Dash, Director Customer Success at Carpel. Welcome to yet another episode of Unboxing AI, where we connect with our partners, collaborators, friends, and the best minds in industry. This is episode number 63. Thank you so much for joining. Today, we have a special guest and we are working with him very closely. It's an absolute pleasure to have him here in the 63rd episode of Unboxing AI at Carpel. If you don't know what Carpel is world's largest AI marketplace and world's only FDA cleared and CE marked platform. It is an enterprising imaging infra-agnostic platform allowing you to build, test, deploy, and monitor AI in clinical workflows and eventually get exponential ROI from AI. With extreme pleasure, I would like to welcome Stefan Iarka, the CEO and co-founder of Rayscape. With a background in computer science and a strong understanding of healthcare workflows, he co founded Rayscape with a mission to enhance diagnostic accuracy and efficiency through clinically validated AI solutions. Welcome, Stefan, and thank you so much for joining this.
Thank you very much for having me. Hello.
Yeah, absolutely. So today, Stefan, so this is Rayscape is such a neighborhood partner of our like AI partner. So as a health tech AI company, it's developing AI powered tools that support radiologists in analysis of chest X-ray and lung CT scans. Would you like to add anything about Rayscape?
No, so I think you summed it up pretty well. We were co-founded a couple of years back, and since then we're assisting radiologists in analyzing medical images. Our tools currently focus on the chest, so you have chest X-ray analysis, lung CT analysis, with prior, of course, available. And we're super excited to be partnered up with you guys. And again, thank you very much for having us on this webinar.
Thank you so much. So, those of you who are here, please feel free to ask questions. We will prioritize questions over our conversation. So, use the chat box or Q&A to put questions. So, Stefan, to start with, I would like to ask, you co-founded Rayscape at a time when you were completing your undergrad and when AI in radiology was still in its early days. What inspired you to take the leap into this field?
Right. So I think our co-founding story and my story, to be frank, is very linked with the story of the other three co-founders that we started Rayscape with. We were all in the same undergraduate course here in our hometown in Romania, and basically we started dabbling, so to speak, into startups 2 years prior to Rayscape. So we started going at competitions, found out about the startup world, how it works. We are passionate about AI, so our know-how was in the AI area. We're computer scientists as background. And we had two other prior startups. The first one was doing something completely different. It was warehouse management systems, doesn't matter. The second one, we tried to do actually schizophrenia detection in a person's speech with AI. So we already were applying AI to healthcare from that point on. But we drew a couple of lessons from that startup. And basically, we quickly understood that we needed to pivot, and we started searching for problems in the healthcare field to try to fix with artificial intelligence, right? And it became very clear to us that radiology has one of these problems. There's more and more images generated. There's not enough radiologists, and they just have more and more work to do, right? So we thought, okay, let's give it a shot, and this is basically how we started. Again, we come from a background of computer science, but very quickly we brought in medical advisors and radiologists into a team because we were just a bunch of maybe not kids, but let's say early teenagers, in our early teens, trying to work with well-known professors and so on and so forth.
That was actually my next question. So I was very curious, how big is your core engineering team now, and what was it like when you started it?
Right. So we started four again. I haven't done any computer science since starting, so I haven't coded a thing. I've only been doing business development, so on and so forth. The guys, they stayed on the coding side. So we, from the beginning on the coding side, we were sort of well prepared. Right now, the team is 20 people. Like there's probably around 9, 10, yeah, more technical. But of course, we have regulatory, we have radiologists, we have business people. So yeah, yeah.
Okay. Uh, when did you bring the clinical team? Was it like in the beginning, or is it a challenge getting the radiologist on board because you all four are undergrad students? So how it actually was it challenging?
Right. So I, it was definitely challenging at the beginning, right? This was early days. I mean, ECR and conferences like this, there were already some speeches, actually quite a few speeches about AI, but it definitely wasn't. It wasn't big podiums with AI or as we have today, right? So people didn't necessarily hear about it that much. So yeah, when trying to reach out, because right after we started, the first thing we did was try to get someone, a radiologist, on board, or multiple if possible. So it's the first thing that we tried to do, and we had to go through a couple of discussions initially to get to someone that would be open. But fortunately, we encountered Professor Brăseșteanu, which is a well-known professor here in Romania, and he introduced us to Marius Bența, which is our chief medical officer right now. And from then, the team of radiologists working with Rayscape and in Rayscape has expanded. So yeah, but it took us quite a little while initially.
Okay, amazing, amazing journey. So again, getting a bit deeper into tech. So I know there are a lot of libraries in Python now that can tackle image recognition. But what was your pilot plan back in 2018 when you just started? Like, what was the core thing your solution was doing? I'm sure that is not 162 uh, findings, what is right now. So what was it then?
Sure. So basically, back then, we had a bit of luck from that perspective because it was sort of coinciding with the period in time in which one of the biggest public available data sets was also put out there, I think, by the Stanford team, or I'm not really sure Stanford, Harvard, but I think Stanford. ChecksNet it was named. So that basically allowed us to quickly build something that we, you know, could have a prototype of on those classes that were on the data set. So we just, ran our algorithms over those data sets, and that's a proof of concept that we had to start talking to our radiologists, to potential radiologists actually. And then after we got actual radiologists on a team, we understood that we definitely needed to recreate the classes, the class structure from that was already in the data set, and we also needed data. So we started working on those two different tasks. It took us a little while to figure out exactly, what the new structure and how we have a lot of findings in the data set, as you know, but we restructured them in like 17 large classes. So it took us quite a little to come up with this list, also to get a data and to get the annotations on the data to be able to actually build a commercial product. But yeah, it's what I've been working on at the beginning. It definitely the chest X-ray product, and the initial structure, the first ever structure, was very similar to ChecksNet because it was about the same time the data set was coming out.
Does that have the same number?
Maybe as just another point. So we also have the CT product that came maybe 1 year later or something like that. So again, initially our focus was chest X-ray. Then based on feedback, we understood, okay, there might be something on lung nodules as well, since it's such a tedious work for radiologists. So yeah, it's how we decided to, okay, let's go into
Started
that
with
as well.
started with I think the similar number of findings with just expert. So I think around 14, 15. So how
Yeah,
long?
exactly.
Yeah, how long it took you to from 14 to 162?
Yeah, right. So the current number of findings that we have, we developed in, again, fairly in the early days, together with the team of radiologists that we had just onboarded, right? Before actually starting to go into a lot of labeling process, so on and so forth, we thought, okay, let's think of how we can structure this so that it makes sense. We did that, it's hard for me to remember exactly how much it took, but it took probably a couple of months, and then we started the labeling process, and then things started moving from that point on. Yeah.
So, with so many advancement happening in medical imaging AI, it can be challenging, particularly with chest X-ray, I can say. It can be challenging for clinicians to choose the right partner. In a crowded AI, chest X-ray AI's landscape, how do you ensure your solution truly earns radiologists' trust?
Sure. So that's actually a very, very good question. There's a lot of tools out there, and most tools they're good. So even when meeting with competitors, we see all tools are fairly good. What specifically on chest X-ray, what we are trying, what our unique selling point is we have a package of features that is the most comprehensive on the market. So along with the findings, which you have already mentioned. We are also able to do cardiothoracic ratio calculation automatically. We show a nice segmentation that allows radiologists to double check whether it's actually true or not, which some radiologists love and some radiologists just don't really use. It's a funny feature. And then there's the bone suppression, bone subtracted images that we are able to generate. So those are initially those were coming from double exposure methods on the machines. So we're able to expose two times very, very quickly at different frequencies, and basically that would give a very interesting image of the ribs that would make fractures clear, and then you could subtract that from the original, and you could see the soft tissue, so you can see better everything that's not fracture related, basically. So um, we are able to do it just purely through AI. So we're generating that, which is fairly cool because you don't have to expose the patient anymore. You also don't need the double exposure module, right? And then we also had, and we still have it. It's probably not a strong use case right now, but we had adapted the CORAD score, the COVID CORAD score on chest X-ray, and we had an algorithm that was able to follow the CORAD score on chest X-ray and suggest a level of COVID, potentially COVID being there or not on images. Again, this is not that used today, but all these features that we package into Rayscape bring radiologists true value, and this is sort of the main differentiator that we have on chest X-ray.
Amazing. Great. So, you are a strong advocate for the responsible adoption of AI in medicine. What one thing the industry still gets wrong about integrating AI into clinical workflow?
Sure. So generally, I think, and luckily, the industry is doing a fairly good job in being transparent with the algorithms and being straightforward. I would say what's very, very important is setting expectations right. AI is, of course, it's a cliche these days, but it's not a replacement, as everyone knows. But not only it's not a replacement, it thinks in a bit of a different way, in which us as humans are not necessarily used to. So it can detect very, very cool cases, edge cases that maybe otherwise would have been missed. Sometimes it can happen to miss something that potentially for a human it would have been obvious. So I feel like the most important thing is making it clear that AI has very strong points. It also has limitations, making this very transparent to radiologists, and basically setting expectations right with regards to this. And as we go forward, I think, and people use AI more and more, I think they get it, right? So they see it in practice. They see what it can do and what it can't do. And I think this is also one of the reasons why in radiology specifically, people have sort of understood that this is not taking away our jobs. This is here to assist. And yeah, it's together we have a better result. That's the whole point of it.
Yes, same here, same feeling. So, those of you who are here, please feel free to ask questions. Use the chat box or question and answer to put questions. So, let me go with the next question. So, um, every founder's journey is filled with challenges and breakthroughs. You must have yours. So, looking back, what were the toughest hurdle you faced in building Rayscape? And how did that influence you or that influence in your leadership style?
Right. This is a this is a very tough question just because there's a lot of challenges that we had throughout the years. But I'm going to share a very early story of Rayscape. Like this was the first product launch that we had. So we had just labeled. I'm basically picking up from where I left our story earlier with after we started labeling and on our own data sets and with our class structure. We trained the algorithm. We ran through a couple of iterations. We sort of tested it maybe internally, let's say, or we had some images that our radiologists were looking at, and they said, "Ah, that's pretty good. It's doing a good enough job." But initially, Rayscape was actually so it was we didn't have integration with PACS, right? So I mean, we were pulling the data out of PACS, but we had a separate infrastructure, a separate application that you had to open, and this was chest X-rays. So we were going to do our first launch. We actually had a very nice event in a big hospital here in our region. We invited quite a lot of people. Quite a lot of people came. We showcased. It was the first AI in Romania, first AI in radiology. It's quite exciting. And then the next day, okay, we said, okay, now we're gonna start in this hospital. So we started out in the hospital, and we were asking radiologists, what their feedback is and how they feel about the system. But we were seeing that like nobody was using it, right? Which was a bit weird to us because we didn't understand why. Because they were saying, yeah, it's pretty cool, but they were not really using it. So this forced us, of course, to dig deeper and to understand why people were not using it. And um, the answer was related to the application and PACS integration. So we were getting images from the PACS, but we just had our own application, which frankly, for chest X-rays, um, didn't know back then, but maybe it's not the best thing to do. Of course, the first thing that we did was not to get rid of the application, was to make the application faster, which helped. And our system was faster. It was more adopted, but we were not seeing as much adoption as we would have wanted to see, right?
Yeah.
So, and I still remember when I had a call with Christy, our CTO, about it. I was driving, and we basically came up with the idea. Okay, let's just cut the application out of this, right? Let's cut it out. Let's see if we just send the results into the PACS. How are people going to relate to it? And we instantly basically saw a much higher level of engagement, right? Because sometimes it's not even about the performance of the algorithm. Of course, this is very important, but the way these algorithms are delivered into radiologist systems is extremely important because radiologists don't have time to waste on many other additional steps. And basically, that from that point on, we said, okay, no more application. We're not going to do any application. Of course, couple of years have passed. Now we're also doing CT. We have a much better understanding of everything of what we're doing. So I think that for CT specifically, for some screening use cases, some modifications might be needed, and then an application makes sense. But yeah, this is definitely one of the challenges that we had. It was very early on, and definitely has shaped how we did things at Rayscape going forward.
Great. So we got some questions. The first question is from Alex Glenn. So, are there also false positives? Have you seen increases in incidentaloma reporting?
Uh, I, as I basically mentioned, I think all AIs are going to have false positives, right? So you're going to have false positives, sometimes probably potentially false negatives. Of course, it's much more important you don't get that. The whole point is you get to the stage in which you have a high enough accuracy so that potential false positives are not over encumbering the radiologist. It doesn't become useless, because if you get too many, then it's useless. And I would say early days, we probably also faced some issues with this. But fortunately, we've been able to remedy pretty much everything that has come up since then. So quite a lot of improvements. And one thing that we've seen, and we've put a lot of emphasis on this, is what we call generalization. So you can have it work very well and without false positives in my hometown hospital, right? But then if you go to Berlin or whatever other hospital, the algorithm can start underperforming. And this is because populations differ, acquisition parameters differ, a lot of things are different for hospitals to hospitals, right? Well, there's a couple of things that we're doing specifically to combat this. And again, we've put a lot of effort, and we actually published a couple of papers on this. I think this is extremely important, specifically to mitigate false positives, so that again, you get to this point in which it's useful to the radiologist, even if sometimes it might be a bit too sensitive.
Right, great. There's another question from Shruti from Kapil. So, what has been the challenging for you, building the AI model or getting hospitals or getting the RADs to use it?
Right. So, right. I think coming from a technical background, probably this has always been our strong point, right? So we're computer scientists. So even though it might have been challenging, we were very used to doing it. So at the end of the day, I wouldn't say that that was the biggest problem. Adoption once in a hospital, I think adoption uh, also was sort of settled, especially after we got rid of the interface. So if they test it, most people like it and they're happy with it, and then they use it. So and then they're happy to give feedback and so on and so forth. So I wouldn't see we've necessarily seen adoption problems as well. Getting into as many hospitals as possible, I would say is has been is the biggest challenge. But this is not because um, for a lack of hospitals in which we were able to enter, because we have entered a significant amount of hospitals. Um, it's the kind of metric that you always can do better at. So you always could have entered more hospitals each quarter, right? So probably, since we're also fairly ambitious in our goals, it's something that we always feel like we could have pushed more and do more on. But yeah, we're fairly happy anyway.
Yes, great. So one more questions we have. Let me see. This is Dr. Ridhima from Carpal as well. So how deeply do people building the AI get into the medicine of the use cases for the models they're building?
Right. So if you manage to establish cross-domain teams, and there's no way you're going to build this without cross-domain teams, what ends up happening is, whether you like it or not, people from the technical team are going to start to understand medical concepts. Of course, they're not going to grasp them super in depth. They're not going to be like not to become like a medical doctor, even if they do it for 1 year, 2 years. But if you work for 2 years in this field, of course you are going to understand at least a couple of the terms, at least a couple of the main mechanics of radiologists doing their work. So I would say, and I'm seeing this with our head of AI and with our great AI team, they do have an understanding at least the basis of understanding of how things work in radiology. And I remember specifically on chest X-ray, it was a fun thing. Probably it was also earlier days. One of the co-founders, the head of AI, Bogdan, was actually looking on YouTube videos explaining how to detect pneumothorax on chest X-rays because he wanted to see whether the algorithm is right or not without waiting for the radiologist to input anything. So you get that as well, which is funny. But again, on a more serious note, I think that without going into too much depth into the terms or really penetrating the subject, but people do get an understanding of how things work and what the mechanics are for sure. At least if you want to have a strong product.
Great. So, at the beginning, you said that you have a small team of like 10 engineers and the 10 tech people. So, how generally you handle the support, like the customer queries or the customer issues when your application is deployed in a live environment or in a emergency department? How the support works?
Sure. So I would say, again, since our technical background, we've been using tools very efficiently.
Mhm.
So very much of our workflow in terms of maintenance and support is automated up to a point. And also, since we have a strong technical team, we're fairly quickly to intervene. Let's say on the customer side, we also have people that are dedicated on the customer success purely. But this is a place where we are also helped by our partners. So whenever there's a problem with a system, if we let's say partner up with someone for that specific place, many times partner are in contact quickly with us, and basically we rush in to fix the issue as soon as possible. So even though we're currently deployed in 14 markets right now, and have quite a lot of deployments and analyze a significant number of medical images each month, we are able to provide very quick response times and fix issues very quickly.
Amazing, great. So there are two questions, one from an anonymous attendee. I'm just going to read out that. Who do you think is your biggest competition?
Right. It's a it's a tough one because it's a competitive field. This must have been one of the competitors asking. No, I'm joking. It's a very competitive field, and there's a lot of great companies out there. So I don't really want to name someone because it's like one biggest competitor. Because frankly, we look at everyone in the field and we believe everyone is doing right things and has certain strong points. And for us, everyone is a strong competitor, or at least that's how we look at it. What I would say though is that ultimately, even though it's a competitive field, and it is, and even though we end up fighting over a couple of hospitals sometimes, ultimately, radiology is such a big field in itself that I think that even right now, we're like maybe 8 years deep into this AI radiology stuff. Even right now, having multiple companies spreading the word and making the technology more well known, at the end of the day, is a net positive for all. So I think the market is still in that spot in which just simply having companies talking about it is actually helpful. So
Mm,
yeah, there's competition, but there's also benefits to having strong competitors, I would say.
great. Yes, absolutely. So there are one question with two parts. So looking at the time, I'll ask the first one only. So what kind of medical inputs are taken before the model is even started to put together?
Right. So I just gonna try to rush through it. So um, I would say we really want to understand what radiologists need, like what's their workflow, what is the biggest pain in their workflow, and then of course there's multiple types of radiologists and hospitals and so on and so forth. So we try to group that up by niche and really understand what types of radiologists need this, what types of so that's the basis of it, and then you start thinking about how to design the classes, how to design the model, and this initially without talking any architecture AI, it's a purely medical task. So you need to really grasp how you can put everything that's relevant into this model from a medical perspective, because if you get the medical perspective wrong, then you're not going to have a good model. So I would say it's definitely a lot of brainstorming and thinking and going over multiple ideas on a medical perspective before doing anything, writing a line of code.
Yes, thank you so much. So we are absolutely reaching the last minute. So
Yes.
thank you so much, everyone. Thank you so much, Stefan, specifically for joining this. Thank you so much, everyone, for joining us. See you next week in our weekly webinar series, which is every Thursday at 11 a.m. ET. Thank you so much.
Thank you very much, everyone. Thank you. Thank you.
Thank you.